Okay, good evening, everybody. Thank you for joining us for the IDF Forum, Antibiotic Prophylaxis and Primary Immunodeficiency. I'm Rachel Delaney. I'll be your forum MC for this evening. Before we begin, this is a quick disclaimer that the information presented during this event is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of a physician or other qualified health provider with questions concerning a medical condition or before starting an exercise program. On behalf of the Immunodeficiency Foundation, welcome. Whether this is the first time you've attended an IDF forum or you've joined us before, we're honored to have you with us tonight. IDF's mission is improving the diagnosis, treatment, and quality of life of people affected by primary immunodeficiency through fostering a community empowered by advocacy, education, and research. This means that we're committed to serving you and providing you with the tools and resources needed to be your own best advocate and champion for the PI community. It's by offering these tools and resources that IDF can fulfill its vision of seeking to ensure that everyone in the US affected by PI has a fully informed understanding of the diagnosis that affects them, all available treatment options, the expected standard of care, and all of the opportunities for connection and support within the PI community. IDF forums are made possible by our wonderful sponsors. It's due to their partnerships and contributions that the IDF is able to provide programs such as this one and services to everyone in the PI community. Thank you to our 2021 sponsors, CSL Behring, Grifols, Takeda, Horizon Therapeutics, Octapharma, Accredo, ADMA Biologics, Bioproducts Laboratories, Farming Healthcare, X4 Pharmaceuticals, Kedrion Biopharma, and Solio Health. Now, I would like to welcome and introduce our presenter, Dr. Alexandra Freeman. Dr. Freeman is board certified in pediatric infectious diseases. She is the director of the Primary Immunodeficiency Clinic and Laboratory of Clinical Immunology and Microbiology at the National Institute of Allergy and Infectious Diseases at the National Institute of Health. At this time, please join me in welcoming Dr. Alexandra Freeman.
Thank you. Thank you so much for the invitation. I'm happy to spend some time talking to all of you tonight about antibiotic prophylaxis. Okay, so tonight we're going to be talking a little bit about preventing infections and primary immune deficiencies. So I think over the next, I think it's like 20 minutes or so, and then I will open it up for some questions. I'm going to review some of the common microbes and some of the common antibiotics that we see in primary immune deficiency and the antibiotics that we use to treat infections. And we'll talk some ways both with antimicrobials like antibiotics as well as non-antibiotic ways to prevent infections. And I'll talk a little bit of vaccination. We can talk about COVID vaccination if people would like, and then there'll be plenty of time for questions as well. So there's a lot of diversity in the germs that we treat, and there's a lot of diversity also in the type of antimicrobials. By antimicrobials, I mean antibiotics, antifungals, and antivirals that we prescribe. And there's also a lot of diversity in the underlying immune deficiencies. When we say primary immune deficiency, there's a big difference between a baby that has severe combined immune deficiency and, someone that has CVID, for instance, or someone with chronic granulomatous disease. So I'll try to touch on some of the different primary immune deficiencies tonight. So I'm going to start by showing some examples of the microbes, bacteria or viruses or fungus that we see in primary immune deficiencies. And then we'll talk a little bit about the treatments, and I'll go through some of the specific treatments. So here's just some examples of things that we see. So you can see on top here, there's pneumocystis that you can see, for instance, in babies with severe combined immune deficiency, aspergillus, which is a mold. There's a picture of Candida. Here's a virus. This one is zoster virus, cryptosporidium, which is a parasite, nontuberculous mycobacteria, strep pneumo, it's a strep, staph aureus, pseudomonas. And then with these different microbes, I highlighted some of the main primary immune deficiencies where you see this. For instance, in pneumocystis, you can see this in the severe combined immune deficiencies SCID, and also in children or adults with combined immune deficiency. So something where it affects both your T lymphocytes that do more the kind of viruses, as well as the B lymphocytes, the antibody making ones. And here's aspergillus, which we can see a lot in certain immune deficiencies, such as chronic granulomatous disease, or in something I see a lot, hyper IgE syndrome, or in others that have trouble with, pulmonary, with bronchiectasis that might have some mold that gets infected there too. Here's a picture of Candida, and we can see a lot of trouble with candidiasis, like thrush, for instance, in hyper IgE syndrome, in APOSID, and SCID, and STAT1 gain of function. Here's a picture of the zoster virus, which we can see causing a lot of trouble, for instance, in combined immune deficiencies. Some of the parasites like Cryptosporidia that we see in hyper IgM or in DOC8 deficiency. The non-tuberculous mycobacteria that can be seen in some of the really, really rare immune deficiencies where it gets widespread throughout the body, or in those with bronchiectasis where it can infect the lungs. Strep pneumo, which can cause pneumonias, for instance, or ear or sinus infections. And those with CVID or XLA or other antibody-related immune deficiencies. This is Staph aureus. That's a big problem in many immune deficiencies, but in chronic granulomatous disease and hyper IgE syndrome. And Pseudomonas, that can be a really problematic bacterial infection in those that have bronchiectasis related, for instance, to CVID or XLA or hyper IgE syndrome. So then how do we treat these infections? So I put up some of the main antibiotics or antivirals or antifungals, and then in the next several slides, we'll start talking about those a little bit more. So pneumocystis, we typically use trimethopym sulfamethoxazole or Bactrim. For aspergillus, we use the antifungals like posaconazole, voriconazole, isavuconazole. For Candida, we'll use ones like fluconazole. For the viruses, we have a lot less options. So acyclovir or valacyclovir are the most common ones. For Cryptosporidia, again, for parasites, there's not a lot, but nitazoxanide. For the mycobacteria, usually azithromycin combined with other antibiotics. For strep pneumo, things like amoxicillin or cephalosporins, levofloxacin. For Staph aureus, ones like cephalexin, or sometimes things like augmentin, clindamycin, linezolid, or trimethoprim sulfa. And Pseudomonas, often we need IV antibiotics or inhaled antibiotics, or sometimes you can use orally with Cipro. And then in terms of prophylaxis, how do we prevent these infections? Whoopsie, sorry. So pneumocystis, that's when people are often put on Bactrim or trimethoprim sulfa for 3 days a week. There's also some inhaled methods, such as inhaled pentamidine. For fungal infections, often we'll use a less powerful antifungal like itraconazole. For the yeast, we can use fluconazole or things like nystatin. The same antivirals. For Cryptosporidium, it's more avoiding with clean water. Non-tuberculous mycobacteria with azithromycin. For those that have trouble with strep pneumo, we'll maybe use amoxicillin, or maybe it's just immune globulin replacement. For Staph aureus, often we'll use something like Bactrim. And Pseudomonas, it's often also kind of addressing some of the issues with bronchiectasis, such as with airway clearance. Okay, so now I'm going to go through some of the common antibiotics we use. So one is the penicillin family. So within the penicillin family, probably the most common one is amoxicillin, or you can have the expanded coverage with amoxicillin clavulanate. That goes by the trade name of Augmentin. So why do we like these antibiotics? Well, they've been around forever. These are penicillins that we all know. They're well tolerated when they're used long term. But some people can be allergic to those and end up with a rash. And if someone isn't sure if they're allergic, then allergists do have very good skin testing to see if there is a penicillin allergy or not. And generally, they're well tolerated. Sometimes there can be diarrhea, but not much else. And they're very good coverage for people that have trouble with antibody deficiencies, such as XLA or CVID, or those without a spleen, because they're pretty good at preventing infections with Streptococcus pneumonia or other common organisms causing pneumonia. And this is just an example of some of the infections that we may use them to treat. This is on top. That's a CAT scan showing of the head, kind of cut through the sinuses, showing a sinus infection. And then the CAT scan below is actually of the lungs. You can see over on this side where the lungs with the black is the air looks quite normal. And then this big white patch is a pneumonia from In this case, could be from Streptococcus pneumonia, which often you can treat with amoxicillin. The downside to the penicillins is there is a lot of resistance that has increased in recent years. And then another common antibiotic we use is trimethopym sulfamethoxazole, or Bactrim for short. So why do we like this? Again, it's a very old antibiotic and it's extraordinarily well tolerated long-term, has a very long track record. We've had people with primary immune deficiencies who've been on this for many, many decades without problems. Also, the way that bacteria become resistant to Bactrim is different than how, for instance, they become resistant to amoxicillin. So if a bacteria like Staph is resistant to amoxicillin, it won't also be resistant to, or not necessarily resistant to trimethoprim sulfa or Bactrim. It also gives protection against pneumocystis. That's why babies, for instance, with severe combined immune deficiency, or children or adults with other combined immune deficiencies are on this. It gives coverage for some Staph, including some of the community-acquired MRSAs. And then the dosing of this depends on why we're using it. For instance, if we're trying to prevent Staph infections with Bactrim, we will use it once a day or twice a day every single day. But if it's being used to prevent pneumocystis, like PCP, PJP pneumonia, then we only need to use it 3 days a week, like Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, or sometimes even Monday, Tuesday, Wednesday. The downsides is some people are allergic, and sometimes the allergist can actually work with people to try to desensitize one to that allergy. It can cause some kind of decrease of the bone marrow if it's used at very high doses. But that's really rare if you're just using it for prophylaxis. Rarely it can cause liver toxicity, but that's really rare. And here again are some examples of diseases that we might use this in and infections we might be preventing. The CAT scan on top is a CAT scan of an individual that has chronic granulomatous disease, and the patches of pneumonia, these white patches, are from nocardia, and Bactrim is extremely good at preventing nocardia infection. Below is an individual with hyper IgE syndrome, and this is an example of a Staph aureus pneumonia, and Staph aureus pneumonias can often be prevented with Bactrim. Okay. The next one is azithromycin. Azithromycin, this is something that people sometimes take as a Z-Pack, for instance. We like it because it's, again, very well tolerated. You can dose it daily, or sometimes if it's being used for bronchiectasis, it can be used just 3 days a week. And it's good for some sinopulmonary infections. Like, it has okay protection against things like streps and H flu, but it also has very good protection against environmental mycobacteria. This is the like MAC. These are bacteria that can live in the soil that can cause problems for certain primary immune deficiencies. It also has some anti-inflammatory properties. So we know from those with cystic fibrosis who have bronchiectasis, that kind of scarring chronic inflammation in the lung, that it can help prevent some of the bronchiectasis exacerbations. And we see that in those with primary immune deficiency who have bronchiectasis as well. So here you can see a CAT scan of an individual with hyper IgE syndrome who has this kind of these dilated airways from bronchiectasis. And in this individual, we use azithromycin to help prevent the frequency of the Pseudomonas flares. The downside, usually azithromycin is extremely well tolerated, but some people can have some nausea or diarrhea. Resistance to things like strep pneumo or staph can form fairly easily, and rarely it can cause changes in the heart rhythms or arrhythmias. So usually not on its own, but if it's combined with other medications that can affect certain intervals of the heart rhythm, the QTC interval, we like to check an EKG and make sure that it's not a problem. Okay, then moving on to the fluoroquinolones. So this is levofloxacin, ciprofloxacin. We don't usually use these for prophylaxis, but I thought I'd mention them just because they're used a lot for treatment. So, these are great antibiotics because they're the only one that can treat Pseudomonas, and Pseudomonas is a common bacteria that can cause trouble when people have bronchiectasis. And it has great spectrum for pneumonias because it treats both things like strep pneumo as well as Pseudomonas, but also some of these atypical kind of walking pneumonias like mycoplasma. The downside is that they can easily become resistant for the Pseudomonas, and it can cause some joint pains, especially if they're combined with steroids. It can lead to tendon ruptures, and they rarely can have some other kind of blood vessel effects. And for the heart, it is one of those medicines, again, that can change one of the intervals that's seen on the EKG. So for instance, if it's combined with azithromycin, an EKG needs to be checked. Also can infrequently cause some things like diarrhea. Okay, antifungals. So there's not as many antifungals as there are antibiotics, because I didn't even go through tons of the other antibiotics. I mostly focus on ones that we use commonly that are oral. Antifungal, so the most simple one is fluconazole that can be used orally. Actually, the most simple one is kind of the swishes and swallows, like the nystatins that can also be in creams. But fluconazole is a antifungal that's very good for Candida, as well as some of the other yeasts that are in the environment, such as coccidioides, which is in the southwest of the United States, causes valley fever, and cryptococcus that can rarely cause meningitis. But fluconazole does not prevent mold infections such as aspergillus. So it's very good for instance, yeast, thrush in the mouth. You can see on this top picture, that's the inside of someone's mouth, and the little white spots are from yeast. That's a thrush infection. Or in this picture below with the fingernails showing yeast. Itraconazole, which is the next one I have listed there, it provides protection against yeast, but also provides some protection against molds. So it's not as good to treat molds, but it's very good to prevent molds. And it's been studied in chronic granulomatous disease and shown that it can prevent mold infections. This one's a little funny because it comes as liquid or pills, and the liquid is actually absorbed a little bit better than the pills. But for prophylaxis, it usually doesn't matter. But this is a medicine that does better if you take it with something acidic like orange juice. It can interact some with things like steroids, such as prednisone, so you have to be a little bit careful with those, but they can be used together. Voriconazole is another one. Now, voriconazole is much more powerful than the other two. It's against yeast, but also against molds that are in the environment, like aspergillus. So you can see in the picture, kind of on the bottom here, this is a chest CT with the like a hole in the lung there, and this little patch of white is actually aspergillus that's moved in there, causing some problems. So one of the downsides of voriconazole is that it can make people very sensitive to the sun. You really need sunscreen, or we try to limit having people on it long term because it can cause sun sensitivity, and long term then can cause some skin cancer. Can be a little bit hard on the liver sometimes too, and can actually cause some increase in fluoride levels. Posaconazole is similar to voriconazole, but I prefer it sometimes because it doesn't have the skin changes with the sun, or the skin cancers or the fluoride issues. It can also affect the liver rarely, and can interact some with prednisone. There's some others like isavuconazole, which I won't talk much about, but it's very similar to the other two. Amphotericin is typically only given IV to treat systemic infections, but can sometimes be made into a suspension for thrush as well. And then the other antifungals are available IV only. I listed some there, megafungin, caspofungin, and those are very good for Candida infections too, but they're IV. Antivirals. So there's very limited choices for viruses. Viruses in general rely a lot on the immune system. So most of them don't have good antivirals. Oopsie, there's a misspelling there, norovirus. That should be norovirus, that causes diarrhea. That's one that can be a problem in primary immune deficiency, and we really don't have great therapy for it. But the antivirals that are available that we do use sometimes for prophylaxis are acyclovir or valacyclovir. They're very good at preventing herpes or shingles, and they're very well tolerated. People can be on them for many, many years. And they're used frequently in individuals with primary immune deficiencies that affect the T lymphocytes, like SCID, combined immune deficiencies, and I listed some specific ones there that we see a lot at NIH, GATA2 and DOC8 deficiency. And here is a child with a stripe of shingles that could then be treated with acyclovir or valacyclovir, but also used for prevention. Ganciclovir and foscarnet are actually used for CMV, which most people with primary immune deficiencies aren't on long-term, but we do use them in the bone marrow setting, so I thought I'd mention them. Oseltamivir, that's Tamiflu, that can be used for influenza treatment after exposure, or as prophylaxis. And then I threw in the antiviral that is used sometimes for COVID-19, which is remdesivir. It's only available IV. For COVID-19 also, If individuals are not hospitalized or needing oxygen, monoclonal antibodies are very effective. But I wanted to talk also about non-antibiotic approaches to preventing infections, because it's not just about antibiotics, because with antibiotics, you can have resistance, which can be difficult. So I like to use antiseptics a lot. So for instance, bleach baths or chlorhexidine can be very effective against Staph aureus. So for individuals that have trouble with eczema or with recurrent skin infections, either swimming in chlorinated pools or having dilute bleach baths can be very helpful to decrease the amount of staph on the skin. Other things can also help for those with CVID or XLA, those that need immune globulin replacement. Sometimes if there's breakthrough infections, it's helpful to actually look at the immune globulin trough and see whether or not the individual needs more immune globulin to be more effective at preventing infections. And then, for certain diseases and that have trouble with molds, there are some kind of higher risk exposures that can be avoided. For instance, avoiding mulching or avoiding hay rides. Those can be really difficult in individuals, for instance, with chronic granulomatous disease. This is a chest X-ray on top here with showing like a mulch inhalation causing inflammation in the lung for someone with CGD. And then certain immune deficiencies can have certain trouble with fungi that are in certain parts of the country. So one example of that is coccidioides that causes valley fever in the United States Southwest, so in areas like Arizona. And there's certain primary immune deficiencies like STAT1 gain of function that can have trouble with that specific fungus. And so it's important to then talk to your immunologist or your infectious disease doctor so that you can be on something to prevent that. Clean water supply is important for certain parasites like Cryptosporidia. That can be a problem for certain combined immune deficiencies like CD40 ligand, hyper IgM, or DOC8 deficiency, or avoiding certain things like water parks can be important with that too. And of course, I think we all know after the last year and a half, the importance of washing hands and in recent times of wearing masks as well. I wanted to touch on some of the other things that we do often for people with bronchiectasis. So when you have bronchiectasis, that's from some of the dilation of the airways and after recurrent pneumonias. And when that happens, the mucus can really build up in those airways in the lung, and that can lead to more infections. So it's really important to try to do techniques to try to keep the mucus out of those airways so that the bacteria aren't so happy. I like using hypertonic saline nebs. Either I have 7% there, or sometimes I'll use 3%. It can be a little bit irritating for the lungs, so sometimes then we'll use albuterol first, or use a lower concentration of salt water. There's pulmonary rehab programs that can be really helpful, or airway clearance devices. They're just different types like acapella and aerobica that can be really helpful to prevent exacerbations of bronchiectasis. And then one thing that comes up a lot in my practice is surgical management. It can be overwhelming to go to surgery for instance, sometimes my patients will need a hip replacement or a spine surgery with hardware. And the surgeons get very nervous. Well, what if they get an infection? And so it's really important to have communication between the doctor that's treating you for the primary immune deficiency as well as the surgeon. For instance, to lower the Staph aureus colonization prior to the surgery if Staph aureus is a problem, with things like either bleach baths or chlorhexidine washes, mupirocin in the nose, for instance. And then, for those with bronchiectasis, when you have surgery, that really kind of impairs your airway cleaning. So it's really important to, have different measures in place to have your airway clearance really optimized for the surgery time. And then certain immune deficiencies can have trouble with healing after surgeries as well. Oops. And then vaccination, of course, is very important and to prevent infections. So some people with primary immune deficiencies don't, have normal responses to vaccinations. And that's why, a lot of people end up on immune globulin. And in those cases, it's really important for their close contacts to get vaccinated. So, so not only the vaccination for the person that's immune deficient, but making sure those in the kind of the herd around them are vaccinated as well. Right now, we're just entered flu vaccine season. So it's really important to make sure that, that people have the flu vaccine, both those are immune deficient as well as those around them. And even for those that don't make good antibodies, there does seem to be a role for influenza vaccination. And then, of course, it's important to discuss with your immunologist if there's certain vaccines that you should avoid. For instance, in severe combined immune deficiencies, the live viral vaccines need to be avoided. And that's true in some of the other immune deficiencies as well. And recently, with COVID vaccination, that can be discussed with your immune deficient, with your home team. But generally, it's important not just for the patient, but also for the family. I think many with immune deficiencies know that a booster has been approved as well for those with immune deficiency. Okay, so at that point, I think we will open it up for questions.
Thank you for sharing such wonderful information with us, Dr. Freeman. We really appreciate you being here tonight.
Oh, you're definitely welcome. Happy to do it.
Okay, at this time, I would like to introduce my colleague, Kathy Antela, to moderate the Q&A session with Dr. Freeman. Kathy.
Good evening, everyone. We have many wonderful questions that were submitted before tonight's forum, which I know Dr. Freeman must have read your mind because she answered a lot of them already. And we have a lot more that were added tonight. And I'm going to start right now with the first question. There have been some questions, Dr. Freeman, about managing CVID or with prophylactic antibiotics instead of IG therapy. Do you have any information about that, or any information about, including that would be, are there primary immunodeficiencies that can be just managed with prophylactic antibiotics?
Okay, so I'll start with that last question first. There's all sorts of different primary immune deficiencies because the immune system includes, the different types of white blood cells. So the neutrophils, the lymphocytes, within the lymphocytes, there's the B lymphocytes, the T lymphocytes. So immune globulin replacement therapy is to replace when the B lymphocytes aren't working well. So there's some immune deficiencies like chronic granulomatous disease that, those individuals make antibodies no problem. So immune globulin therapy is not part of their therapy, and they are treated with antibiotics and antifungals as prophylaxis. So, it really is kind of tailored to the type of immune deficiency. If we think about immune globulin replacement therapy, or we think about immune globulin replacement therapy plus antibiotics, or we think about just antibiotics or nothing, and just kind of being careful or whatever. So in terms of CVID and whether or not to be on antibiotics or immune globulin replacement therapy or both. So I think, a lot of people think about whether or not immune globulin replacement therapy is truly necessary when it's just kind of a more of a mild decrease in the total IgG level, or maybe the immune globulin level is, close to normal, but the specific antibody production, like the responses to vaccines, aren't quite perfect. So sometimes in those settings, for instance, we'll initially start with an antibiotic each day, either with something like azithromycin or something like amoxicillin twice a day, and see how it goes. But if there continues to be breakthrough infections, like pneumonias especially, then I think people will sometimes say, oh, the IgG level is still going down a little bit. I think it's time to make that jump and start immune globulin replacement therapy. But I do think sometimes you'll see people where it's just mildly low, the overall IgG level, and it can be up in the air a little bit about what to do next. And I'll say, sometimes, the most common reason to be on immune globulin therapy for CVID or for X-linked agammaglobulinemia, for instance, is when the IgG level is very low or absent. But, for certain diseases, the IgG level is actually normal, but the response to vaccines is very, very abnormal. And in those individuals also, we can think about, well, do we want to start them on replacement, or do we want to think about something like an antibiotic first? And that's true of some of the diseases, that I kind of focus on the most, like hyper IgE syndromes, for instance. So, I'll sometimes put my patients on immune globulin replacement therapy, even though their IgG is okay, if they can't respond to the vaccines. Like I feel like the quality of their antibodies isn't good, even if the quantity is. Okay, then I think, when someone has a very, very low IgG, so, for instance, someone with XLA or someone with CVID who has a very, very low immune globulin level, I think pretty much everyone says, okay, you're going on immune globulin therapy. The question then is, some people end up on an antibiotic plus the IGRT. And I think that is very kind of center dependent and immunologist dependent. But, it's typically, for instance, if, you're on the immune globulin therapy and you're still kind of breaking through and having some infections. And sometimes you see that in the people that have bronchiectasis already when they start the immune globulin therapy. And then it's a little bit easier to end up with an infection, and they'll go on, for instance, azithromycin with immune globulin therapy. So hopefully I answered all the different parts of that question.
Thank you. Yes. What do we do about doctors who like the wait and see method? So you go into urgent care or your PCP and they say, yeah, well, let's wait and see how you are in a few days or a couple days, and then you wind up being sick longer than you normally would be and needing prednisone and antibiotics and so many things to just get better.
Yeah, I think it's really hard. I think, in urgent cares and in ERs, often people don't have a lot of training always about primary immune deficiencies and don't really understand exactly, that the presentation can be a little bit different. I think, I know this is a big problem for a lot of my patients. Sometimes in primary immune deficiencies, even the blood work can look like the white blood cell count, which in an otherwise healthy person might be, super duper high when they have pneumonia, can be relatively normal, and there might not be as much fever. So a lot of the typical signs are not always there, which can make it really tricky. I think it's just hard, right? Like, I'll have my patients try to have, the doctors call me, but, especially recently with COVID and everything, the ER doctors and urgent care places are really busy, and it's very hard to get them to do that. So I think the best thing is then to be able to follow up with the doctor that knows you. If it's an urgent care, maybe you need to be seen that night. Your doctor's not available, in the middle of the night or whatever, but then to follow up pretty quickly with your immunologist or with your primary care doctor, someone that you trust that knows that you don't have all the typical symptoms always.
Thank you.
And one thing I've been doing recently, especially, in the rare instance when, for instance, a patient of mine has COVID, or when they're hospitalized with something, it's hard right now. The doctors and hospitals are really, really busy, the hospitalists. So if you're ever admitted, I'm trying to get my patients to contact me. And I realize not everyone can do this. I mean, I work at a very different place at NIH, so this probably isn't true for a lot of people's immunologists. But I'll be like, okay, just call me when the actual hospitalist comes into the room. Try to get in touch with, our nurse or nurse practitioner or myself, so that we can have that conversation right then. Because I think right now, when a lot of the hospital systems are super duper stressed, it's really hard, for those people to take the time.
Mm-hmm. Couple questions about prophylactic antibiotics and GI issues. And one person said they've been taking clindamycin prophylactically for more than 12 years, and it really causes GI issues. Somebody else too said, how do I manage the GI issues, when I'm taking prophylactic antibiotics or any antibiotics, I guess.
Okay. So certain ones like clindamycin was given as an example there. Clindamycin can be, that's one that can really affect your own kind of healthy bacteria that live in your intestines and can be kind of hard on the gut. So, some people do, and this is something to talk about with your provider, whether or not something like a probiotic can be helpful. Some people do find that, trying to restore some of the normal bacteria or the normal yeast can can be helpful. So that's something to discuss with your provider, or to be on an antibiotic that's a little bit less difficult on the stomach. Sometimes people just eat yogurt that have some of the live colonies inside the yogurt. But yeah, it can be very tricky. And so I think, talking to your own doctor about, either changing to an antibiotic that's a little bit easier on the intestines, or doing something like a probiotic or yogurt or something can be helpful.
And speaking of GI issues, are there any antibiotics that are less likely to cause C. diff?
Yes. So there are some that are more likely. So clindamycin, actually I had a talk version of this before that was a lot longer that I had to shorten down, where I actually talked about C. diff. But so I sort of put in something about that next time. So clindamycin, things like ciprofloxacin, levofloxacin, the fluoroquinolones, I mean, they can be very C. diff inducing at times. So, and it is important to get tested and treated for C. diff if it's present. So, some of the other ones I mentioned, for instance, trimethopym sulfa, that spectrum, that wipes out a lot less of the normal bacteria, and that one's a lot less likely to lead to C. diff. But the more narrow the antibiotic, the better against C. diff.
This person has had sepsis, and then they said they needed to switch their prophylactic antibiotics, and they have added an infectious disease specialist to their care team along with the immunologist in order to manage any possible future issues. Is that something you think is a good combination for somebody in that situation, to have both specialists as long as they're talking to each other?
Yeah, no, I mean, I'm an infectious disease doctor that primarily sees people with primary immunodeficiency. So I think infectious disease doctors are the best. So, I'm a little bit biased. No, I mean, and I work really closely with immunologists. So, my own group is a mix of infectious disease doctors and immunologists. So I think it's really great to have that combination, as long as they are on the same page and can get along and talk to each other. I mean, it's a really good point that, you have to have them talking to each other, because, sometimes they mean, I am from the infectious disease side where, we worry about things like antimicrobial resistance and things like that. But, sometimes in the world of primary immunodeficiency, the kind of the global antibiotic resistance might not pertain as much to an individual. So, sometimes there can be a little friction in between an immunologist and an infectious disease doctor in that way. But I think it's a good combination to have. I think they think about things a little bit more differently. I always felt like, the immunologists are really good at knowing every single esoteric gene that's causing all the different primary immune deficiencies. There's like a new gene like every other day, that's identified as causing primary immune deficiencies. But the infectious disease doctors are used to the management. But, we all do similar things and all can work very well together.
Well, speaking of resistance, we have quite a few, and I know you talked a little bit about this, but we have quite a few questions about resistance and occurring in the PI community when you're taking prophylactic antibiotics prophylactically, and should you be rotating, and what can you do? What can you do?
Yeah, those are great questions. I'm not a big fan of the rotating antibiotics. I feel like, then you're just setting up your body to see multiple antibiotics more frequently. So, I think I come from a group, I was kind of trained by a group that was less, interested in that, and, for concerns with increased resistance. So, that's why I try for my own patients when I can, for instance, for staff, I really try to have my prophylactic be something that won't cause resistance or cause problems for an antibiotic I might use to treat. For instance, if someone's on Bactrim for prophylaxis, trimethopym sulfa, and let's say they get frequent lung infections or sinus infections or ear infections, that's not going to be my go-to choice. So then they get a bad sinus infection, and maybe I'll use amoxicillin clavulinate, that's trade name Augmentin, you know, for that. Well, the Bactrim doesn't cause resistance for the Augmentin. So I think, you know, I try to think about things like that when I'm doing, when I'm coming up with my prophylaxis. And then in my head, I'm like, okay, now when they get sick, what am I going to do? I think for certain antibiotic resistance like MRSA, you know, I really think the antiseptics can be super helpful, like the chlorine and the bleach baths and Hibiclens, things like that can be really helpful to prevent resistance.
And this question, I think you answered it, but if there's anything else to add, how do you determine the correct dosage for antibiotic prophylaxis versus when you have an infection? How do you decide, you know,
the dose? Yeah.
Yes, yes.
Yeah, I don't think I really talked about dosing that much, but I talked a little bit about, I guess, for Bactrim. So yeah, usually we do use a little bit lower dose for the prophylaxis than we use to treat the infection. You can't go too low though, if you're worried about an infection that could get resistant. So for instance, if you're trying to prevent staph infections with Bactrim, I usually dose it in adults at 1 double strength twice a day, but every day. Whereas if you're using Bactrim to prevent pneumocystis, you know, 1 single strength 3 days a week is good enough, or 1 double strength 3 days a week. So there are some differences in terms of prophylaxis and in terms of treatment. You know, for instance, if you're using amoxicillin, maybe you'll be using it like 500 milligrams 2 or 3 times a day. But, you know, if then you're moving it up to prophylaxis, you're going to use something up much higher dose, or you'll combine it with clavulinate and use Augmentin. So it is usually a little bit less dose, but not dramatically different.
Do many individuals with PI end up being allergic to antibiotics because they have used them so often, either prophylactically or due to treating infection?
Yeah, using them, you know, I think if you're exposed to more antibiotics, you know, you might end up just having to take one, right, that you're allergic to, because you're using them more often than someone else might. But I think, you know, we don't usually see allergies emerge when people have been on it for many, many months or years, you know. So, you know, after your first few weeks or whatever on amoxicillin or Bactrim or something, you know, we don't see the allergy usually emerge a lot later. So I think, you know, a bunch of people are allergic to antibiotics. You know, sometimes you have to make sure that it's a true allergy also, you know, so a lot of people, right, get rashes for lots of different reasons. And I think, you know, something like a penicillin rash, you know, sometimes, you know, a kid is diagnosed with a penicillin rash, but it turns out that they had a rash from some other virus, or, you know, maybe they outgrew that. So it is, you know, a lot of immunologists are allergy immunologists, and it's really important to have them really check to see, you know, if possible, if the allergy, you know, is it really an allergy that prevents you from taking something? But it can be hard with allergies. And, you know, and every once in a while we will desensitize someone to an antibiotic such as the Bactrim.
Is there a limit to how long someone can take prophylactic antibiotics?
No. So I think being on something like ciprofloxacin or levofloxacin for a really long time is not great for your joints, but the ones like Bactrim, trimethopym sulfa, or amoxicillin, you know, I mean, we've had people with chronic granulomatous disease or hyper IgE syndrome on those for many, many decades, and just fine. So, it depends a little bit which one. You know, for instance, I was talking about that antifungal voriconazole. That's not really a prophylaxis one, but that one can cause problems long term. But like the typical ones like azithromycin, amoxicillin, Bactrim, you can be on for many, many decades as prophylaxis without problems.
How do we know whether we should pre-med with antibiotics before dental work?
I would talk to your immunologist about that. There's different reasons to have prophylaxis before dental work. You know, you know, and it also really depends on the dental work. So, you know, there's certain primary immunodeficiencies that are more prone to dental infections. And there's other times, people have heart issues and they need to get an antibiotic for that with dental work. So yeah, so I have my patients let me know if they're going to have dental work. And usually if it's something like a cleaning, I often won't do prophylaxis for most of them. But, for instance, if it's an extraction of an adult tooth, maybe I will. But I think that one really needs to have a little bit of a discussion because it's kind of like, what are they trying to prevent? Sorry.
How does the desensitization process for Bactrim work? So if you're
so what they, yeah. See, so you, an allergist does that, and I'm not an allergist doctor, but what they do is they give you a teeny, usually in a hospital setting, and depending on what your reaction was in the type of hospital, it might either be on the regular hospital floor, it might be in the ICU, it can depend where it's done. Also, depending on the antibiotic, it might be in the dose that you need, it might be something over a few hours, or it might be something over a couple of days. So they start with a baby teeny dose. And then like maybe, half an hour later, if you're okay, they up the dose, then they up the dose again. So basically they're introducing very small doses and then increasing it to try to trick your immune system into you being okay with it. Once you get desensitized though, if they really thought you had a real reaction, it wasn't just a challenge, and now you're desensitized, then you can't stop that antibiotic. Then they're going to have you take it every single day because otherwise your body needs to get desensitized again.
How do you decide which antibiotic to prescribe for a bacterial infection?
So it depends a little bit on what the bacterial infection is. But, I am a huge believer in trying to get, some sort of culture data so that whatever antibiotic you choose initially, you can narrow it down a couple days later. And that's not easy to do. I feel like, if someone comes in and you're worried about a pneumonia, for instance, you can choose, I'm sorry about I can hear my puppy had a little procedure today and he's kind of crying in the background now. But if you can get a sputum culture and know in a couple days, okay, it's growing, the sputum culture is growing strep pneumo or it's growing Pseudomonas, and then you can narrow it down to the best antibiotic for that a few days later. I think that's really helpful. So, up front, if you're really sick and you need to be on an antibiotic, you can't wait for the culture to come back, then it's really knowing the combination of what your underlying disease is and what the most common bacteria are that you would have trouble with. And then we know which antibiotics to guess. So let's say, for instance, you're someone with CVID and you have a lot of trouble with people with CVID can have trouble with strep pneumo and Haemophilus influenza, those type of infections. And you're coming in with a bad pneumonia. And I'm thinking, okay, it's probably, a strep pneumo or Haemophilus influenza. Maybe I'll use, something like ceftriaxone in the hospital. But, depending on how sick someone is, you might choose something like that, or you might choose something even broader. But, having a culture so that a couple of days later you can say, oh, but you know what? It's sensitive to augmentin. So now a couple of days later, you can go out on an oral augmentin dose. So I think it's really important to try to get a culture, and then, the antibiotics are tested against that culture, and it takes a couple of days. So one thing out there, again, I'm super lucky to work somewhere that has a very good microbiology lab, but, I know because my patients come from all over the country, not every lab is exactly like mine. So one thing I've learned over the years is that if you have bronchiectasis, and people with bronchiectasis can have trouble with Pseudomonas, if you just say, I'm getting a sputum culture, and your doctor just puts it in a sputum culture, sometimes that is only held, they only keep it in the Petri dish for like a day or two. But for Pseudomonas, you really need it to be held for like 3 days. So at certain labs, they'll ask, like some of my patients will have it put in as a cystic fibrosis sputum culture, because then they'll hold it longer for Pseudomonas to grow. So that's important to know for certain labs.
Would you please review airway clearance devices one more time?
Yes. So there's all sorts of different devices, You know, there's anything from vests, like people often with cystic fibrosis use vests, but sometimes people that don't have cystic fibrosis and bronchiectasis, you know, have the things that you put on that kind of shake you a little bit and helps you cough up things. You know, but most of the time that can be very hard to get without cystic fibrosis, and it's kind of a pain sometimes for some people. You know, we use ones, kind of these flutter valves, where you can, it's like a little device that you can breathe into it, either just on whenever, or you can actually sometimes do it while you're getting a neb treatment. There's different ones, but they're like different kind of flutter device. There's one that we use sometimes called Aerobica. It's Aerobika. There's all sorts of them. And then I really like the hypertonic saline nebs too. So either 3% or 7%. So what I'll often do is have my patients do albuterol first to kind of open up the airways, and then like a saltwater neb, and maybe even using one of those devices while they're doing the nebs. The other thing is physical activity is really good for airway clearance. So just, you know, going on a fast walk, for instance, if possible.
When running a fever, should vaccines be avoided during that time?
Yeah, I think it's not a great idea to get a vaccine when you're already sick with something. It just can make you feel more miserable. It's not usually that your body can't react to it, but it's generally advised not to, for the miserable factor too. So I would, for instance, for a flu vaccine, I would wait till the fever is resolved.
My sinuses are colonized with Serratia. How common is this bacteria in individuals with CVID?
So I would say Serratia is not common. It's not unheard of. We can sometimes see it in sinuses or in lung infections or in the skin. It, you know, may or may not be causing a big problem in terms of infection there. So it kind of, you had to look at the whole picture. And sometimes it's selected for if you've been on antibiotics for other things, because, but it can be in the environment and it can be there.
And this will be our last question. In what circumstances, if any, would you recommend individuals with PI to continue wearing masks post-pandemic?
I feel like I'm going to wear my mask forever now in terms of working at the hospital. I feel like it's been so nice not getting colds and stuff. And, you know, I feel like it's been much safer around my patients, you know, in terms of not being worried about giving them something. So, you know, I think we've all learned a lot about masks over the last year and a half, and kind of the situations where they're more important, right? Which is like indoors and closed settings with people, and kind of how, you know, outside, it's so rare to kind of pick up a cold virus, for instance, when you're walking quickly by someone. So I don't know. That's a hard question, because I feel like right now I'm like so still immersed in mask culture. So I think we'll all have to see, you know. I think for a lot of us that are either in the field where we're taking care of people and we're like living in fear all the time that we're going to get COVID and give it to our patients, or for our patients, you know, where it'd be, you know, much more difficult if they got these things. You know, I think it's going to take all of us probably a lot longer than the general community to get rid of the masks. So I don't know. So that, I think that will just be a personal preference.
Thank you, Dr. Freeman. Thank you so much for volunteering your time to be here, to share your wealth of knowledge with us, and cannot thank you enough. And
well, you're very welcome. I was very happy to do it.
Give you a huge round of applause. And right now I'll turn the program back over to Rachel. So thank you.
Thank you, Kathy. Thank you, Dr. Freeman. Thank you again to all of today's featured sponsors: CSL Behring, Grifols, Takeda, Accredo, Farming, X4, and Kedrion. We're honored that you have been able to join us and share information about your resources with us. Once again, thank you all for joining us tonight. We hope that you found the information presented helpful. Please remember, IDF is here for you every step of the way on this journey. We'll see you next time. Bye, everybody.